Hello and greetings to all. So today I am going to present a clinical case study of ultrasound. The code is US06 and let's start. So the patient was 57 years old man with a type 2 diabetes and hypertension who had been known to have an asymptomatic single giant gallstone for at least 10 years. He was admitted through the emergency room at Kuala Lumpur Hospital in December 2019 with a 2-day history of progressively increasing abdominal pain in the right upper quadrant associated with the nausea and the general weakness. On the examination, he was febrile but hemodynamically stable. He was jaundiced. The abdomen was tender, particularly in the upper right quadrant where the gallbladder was palpable with a positive Murphy's sign. Laboratory tests showed a white blood cell count of 17,000 per millimeter cubic, an erythrocyte sedimentation rate of 59 mm in 1 hour, and a C-reactive protein of 38 mg per deciliter. Other blood tests such as blood urea nitrogen, creatinine, glucose, AST, ALT, bilirubin were normal. So this is the ultrasound image that these patients undergo. So in this task, I need to describe the ultrasound examination performed for this patient. Thus, regarding to this image, this patient undergo biliary sonography, which evaluates the imaging of gallbladder along with the intrahepatic ducts, hepatic ducts, cystic ducts, and common bile ducts. It often evaluates the other organs in hepatobiliary system such as liver, biliary tree, pancreas, and so on. When the clinical findings and sonographic findings found in this chapter are consistent with the gallbladder disease, the sonographer should closely evaluate the liver, other parts of the biliary tree, and pancreas for an additional complications such as intrahepatic and extrahepatic biliary tree obstruction and pancreatitis. So, the clinical indication in this ultrasound scanning includes the right upper quadrant pain, jaundice, pyrexia of an unknown origin, and throughout the gallstones. Ultrasound is the modality of choice for evaluation of a patient with the right upper quadrant pain, and it is the highest rated modality in ACR appropriateness criteria. Moreover, in majority of the patients, gallstones are easy to diagnose by demonstrating mobile echogenic intraluminal lesions with acoustic shadowing. In pre-procedure assessment, a review of prior examinations and relevant documents should be performed by sonographer before any contact with the patient. Gathering a complete clinical history includes a review of reports from previous imaging studies such as ultrasound, general X-ray, CT scan, and MRI would probably help in imaging acquisition process and the diagnosis of the examination. Furthermore, sonographers must be capable of analyzing the clinical complaints, which is the signs and symptoms from the patient. The patient-sonographer interaction is exceedingly important in this case. Sonographers must be able to preview pathology results from the laboratory tests when they are available. Helpful lab results to evaluate in the presence of suspected gallbladder disease includes alkaline phosphatase (ALP), alanine aminotransferase (ALT), bilirubin, gamma glutamyl transferase, and white blood cell count. The information about the previous surgery you need to obtain also. This is essential. For instance, if the patient already undergo cholecystectomy, so the sonographer will already have the reason for non-visualization of gallbladder in the ultrasound imaging. Patients who are required to undergo biliary sonogram need to fast for at least 4 hours, although some authors suggest the optimal duration is 8 hours. The reason is when the patient is fasting, the gallbladder is distended and also to reduce the amount of upper abdominal gas produced. However, diagnostic studies can be obtained in the non-fasting patients, especially for those who require an emergency sonogram. Diabetic patients, like in this case, need to be scheduled early in the morning to prevent hypoglycemic episodes from happening. Patient is also advised not to smoke or consume chewing gum before procedure. In this ultrasound scanning, studies are performed with the curvilinear transducers at the frequencies between 3 to 5 MHz. The focal zone placement should be optimized to the lesion of interest, especially with the gallstone. Use of harmonic techniques improves evaluation of gallbladder lumen and increase the tissue contrast with the fewer artifacts. Compound imaging techniques are used to decrease speckle and increase lesion conspicuity. Also, the gallbladder is evaluated in the multiple planes. Patients are imaged in the supine position, but the left lateral decubitus position is essential to ensure that the small stones located in the gallbladder neck are not missed. Additionally, patient movement demonstrates mobility of intraluminal lesions and differentiates stones from polyploid mural lesion. Other useful positions include the right lateral decubitus, semi-erect, erect, and prone. If the patient is immobile, elevation of the head of the bed or the stretcher is an inferior substitute for decubitus or prone positioning. Deep inspiration can improve visualization of the gallbladder and to determine the presence of the sonographic Murphy sign. In imaging the gallbladder, the technique used is transducer is placed at the right subcostal for the both longitudinal and the transverse plane. Traced from the right portal vein to the gallbladder fossa. For intrahepatic ducts of the left lobe liver, transducer is placed at the epigastric in the transverse plane, whereas for the right lobe, transducer is placed at the subcostal or in right intercostal in the oblique plane. For extrahepatic duct, in visualizing common bile duct, transducer is placed at the subcostal or the right intercostal in the oblique plane and anterior to the portal vein, then extend downwards through the head of pancreas to ampulla. So what to look in the gallbladder ultrasound? Gallbladder assessment includes evaluation of the wall for thickness and integrity, gallbladder volume, and intraluminal contents. Assessment of the sonographic Murphy signs is essential. Adjacent structure are also assessed. Also, the measurements are taken from this gallbladder, such as normal preprandial wall thickness is measured less than 3 mm, normal preprandial length less than 11 cm, normal gallbladder lumen less than 4 cm, normal gallbladder wall thickness is less than 3 mm, and normal bile duct diameter less than 6 mm. So for this patient ultrasound image, we come to the part in which we need to interpret the visualization of this image. So in the longitudinal plane of gallbladder image, we can see the visualization of the distended gallbladder with an impacted stone visualized in the neck of gallbladder. There is a presence of posterior acoustic shadowing due to the gallstone, and also the content of gallbladder is full of floating hyperechoic material. Whereas in the transverse plane of the gallbladder image, we can see the mild gallbladder wall thickening and also the wall echo shadow sign, and it is confirming that the presence of the gallstones. So based on the ultrasound images along with the other relevant clinical information, the diagnosis that most likely for this patient is acute cholecystitis. So what is acute cholecystitis? Acute cholecystitis is the condition of the gallbladder inflammation that develops over hours, and it is usually caused by the gallstone that obstruct the cystic duct. It will then cause the patient to have a right upper quadrant abdominal pain along with the nausea, vomiting, fever, and anorexia. In ultrasound, cholecystitis will be visualized as a thickened gallbladder wall, more than 3 mm measurement, a pericholecystic fluid, an impacted stone in the gallbladder, and the tenderness when the gallbladder is palpated with the ultrasound probe, which is also known as a sonographic Murphy sign. All of these conditions above are related with this patient. Next, the discussion by the Tokyo Guidelines Revision Committee concluded that the acute cholecystitis should be suspected when the Murphy signs and the local inflammatory findings in the gallbladder such as right upper quadrant are presented. Also, the diagnosis can be made if the following findings are present, which is the abnormal white blood cell count and elevated CRP level. This condition relates with the inflammation and the infection happened in this patient's body. Moreover, Gutt et al. Demonstrated that adult patients with the signs and symptoms of acute cholecystitis can be detected when at least 3 criteria below have been fulfilled, such as abdominal pain in the right upper quadrant, Murphy sign, leukocytosis or rectal temperature above 38 degrees Celsius. These signs are eligible for enrollment when sonographic signs of cholecystitis had been proven. Other than that, Murphy et al. Said that the acute cholecystitis is usually accompanied with pyrexia and other infective symptoms such as nausea and vomiting. Besides, patients with the diabetes mellitus are thought to be at a higher risk for developing gallstone as well as its complications such as acute cholecystitis. Moreover, ultrasound is the initial imaging modality of choice when acute cholecystitis is suspected clinically. Ultrasound contributes for 95% of sensitivity and 98% of specificity in detecting acute cholecystitis. The advantages includes its widespread availability, lack of ionizing radiation, rapid time to image acquisition, and relatively low cost. Another advantage of ultrasound is its ability to diagnose acute cholecystitis on the basis of the presence of the Murphy sign. Speaking of the Murphy sign, sonographic Murphy sign refers to the pain that occurs when the gallbladder is pressed while it is being depicted with an ultrasound probe. The significance is the positive Murphy sign often indicates cholecystitis, whereas a negative Murphy sign may suggest pyelonephritis and ascending cholangitis. Murphy sign is a useful tool in conjunction with cholelithiasis, having a positive predictive value for acute cholecystitis of 92%. Usually, the treatment of the acute cholecystitis is based on the surgery intent, which is the laparoscopic cholecystectomy. It is a type of keyhole surgery where the gallbladder is removed using special surgical instruments inserted through a number of small cuts in the abdomen. This laparoscopic cholecystectomy may be recommended for the patients for those with gallstones, because these patients are likely to have a recurrent and more severe symptoms. In comparison between early and delayed laparoscopic cholecystectomy, it is said that the early laparoscopic cholecystectomy performed within 2 days of presentation of acute cholecystitis yielded the best outcomes and the lowest cost one. If acute cholecystitis is left untreated, it may progress to other diseases like the gangrenous cholecystitis and the gallbladder perforation. So this is the references, and that's all from me. Thank you.